Good evening, ladies and gentlemen. Welcome to the trial class for AMC First Aid MCQ. My name is Dr. Rabia, and I'm one of the tutors associated with the course. Let's just wait a couple of more minutes before a maximum number of people can join, and then we'll start our trial AMC MCQ class today. Good evening, everyone. During the trial class, if anyone has any issues regarding the voice, please do let me know in the chat box so that I can solve the issue on my end. Also, if you're having your device, make sure the volume is maximum on that. And if anyone has any questions, I will be happy to take those questions in the chat box so that we don't disrupt the class by opening up the mic. We would have a Q&A at the end of the class where you all are welcome to ask me questions about the course. And I will be happy to answer to the best of my ability as much as I know about the course. All right. Let's just wait a couple of more minutes so that maximum number of people can join, and then we can start the class. My voice isn't very audible. Is anyone else having an issue with that? Try to increase the volume of your device so that you can hear the sound. I have checked the settings of my microphone on my end, guys. It's showing green, so that means the signal is loud and clear. Please do check on your device. All right, let's start the trial class today. For those of you who have just joined right now, my name is Rabia Farid. I'm one of the doctors associated with First Aid AMC course. And I'm also one of the tutors as well. My role in this course is to help you go through the sample questions that come in the exams and to help you learn the tricks about how to solve the questions in due time and how to reach the answer. I usually take 2 to 3 sessions, but during this course, I will be taking 4 sessions a month, 1 session every week. It's a class of 2 hours. We go through maximum 30 to 40 questions in a sample question class. In those questions, sometimes because we are getting those questions from the candidates who are sitting the exam in the said month, for example, January students are sending us the questions. Sometimes the questions are incomplete, but my purpose as a tutor is to go through the topic and try to help you guys identify how to reach the answer if they ask the questions in certain ways. The pattern in the exam is the same, but how they ask the questions is different every time. So the topics doesn't change in Australian Medical Council exam. The topics are still the same. It is an entrance level exam. So it doesn't have like specialist level questions. It's questions at the level of the interns, which is house jobbians in some countries. So it's an entrance level questions will be there, but what they do test you is on the basic knowledge and the things that will save the life of the patient. They also test you on ethics as well. There are different subjects they test you on. They test you on general medicine. They test you on population questions. They test you on pediatrics, surgery, orthopedic, which is included in the surgery. They test you on gynecology and obstetric questions, and then they test you on the emergency medicine question. AMC MCQ exam consists of 150 questions, and the number of portions of the questions are divided in these basic 5 sub-subjects. Now, as Dr. Arshan has already given a very good introduction of the course itself, as you all know, it's a 5 months course. So during those 5 months, Dr. Arshan will be going through the subjects topic-wise, general medicine, then surgery, emergency medicine, gynecology, obstetrics, population health, and pediatrics, ethics, and sometimes statistics as well. Now for preparation of the exam, these are the materials that I recommend each and every students that we come across. So your first one is the most basic that you have to, that is very, very important for you to at least go through a couple of times. John Murtagh it's a book for passing the exam. It's a holy grail for passing the exam. If you have done nothing, if you have just stuck to John Murtagh and have your basic concepts very clear, it will help you pass the exam. Now, in the exam as well, you will get questions from a general practitioner perspective as well. So for those kind of questions, RACGP, which is Royal Australian College of General Practitioner guidelines are recommended. John Murtagh and RACGP guidelines are very similar. So John Murtagh is basically based on all the guidelines which is used in the Australian health system. Now, every state has particular guidelines regarding specific topics, and they have websites created for those purposes as well. So the ones we have found most useful for certain subjects are, for example, South Australian Health website is very good for obstetric related topics. New South Wales has very excellent guidelines regarding emergency medicine. Queensland Health also has very good guidelines for emergency medicine. Royal Children's Hospital, its guideline for pediatric age group related topics, and sexually transmitted infection guidelines for anything related to that population. Anyone has any question from here? Please let me know in the chat box if you have questions, okay? All right, happy with that? So I will be going through questions because January just started. So we don't have the questions from the January yet, but I do have questions that came in November, December last year. So we'll be going through 2025 sample questions to give you an idea about what type of questions do come in the exam. And then I'll be pretty much going through how we solve the questions in the exam. Now, initially it will seem very difficult for you to go through and solve the questions at a very fast pace, but everyone starts somewhere. It's quite normal for you to be a bit slow in the beginning, but as you get a good grip um, on the basic concept of the topics asked in the exam, you will see that your pace of solving questions gets much quicker. And if you do implement the tricks I'm going to share with you guys today, it will cut down the time in half. So that saves you time. Because if you don't complete the questions on time, doesn't matter how many correct questions you have opted, if you don't do the 150 questions in 3 hours time, if you have any like 5 or 6 questions remaining and the time goes up, you are marked as a fail in the exam. They don't count the number of questions you have marked right. You need to complete the exam in order to pass the exam as well. All right. No, Dr. Rabia, different states do not follow different guidelines. Every state has, the algorithm is the same. It's just some guidelines are better explained than the others. That's why I have opted like New South Wales for emergency. It gives you very explicit answers that they ask in your exam. Queensland Health for emergency as well. RCH is followed all over Australia. SA Health for obstetrics is followed all over Australia because of how good they have made their guidelines in algorithm form, in the form of um, different tabulations. I will show you guys in this class, okay? All right. Moving on, let's go towards our first question. Now, it will come very similar in the exam. They will give you a picture sometimes. The stamp is quite large. So what's the trick in going through a very big stamp is that you do follow the keywords. Keywords is that, for example, you look at the age, you look at what sex is presenting, and then you look at the symptoms. Let me just bring out the pen. So during my class, you will notice that I underline the key points a lot. And I want you to focus on that key point in solving the question. Don't go towards the options first. Looking at the picture, you will know, oh, it's a question related to dermatology. So 34-year-old woman developed rash on her buttock. Time period is 2 days. Sore to touch. She has no rash anywhere else, so it's a localized rash. She says this has happened at least 3 previous occasions, so it's a recurrent episode. Rash is always in the same plane, so you know it's the same part of the skin that is affected. Now, what is coming on, just looking at the stem, it's a young female, has a rash on a particular part of the body. It's a recurrent and sore rash. What comes in your mind? Don't look at the options. Just what comes in your mind? Sore rashes. What comes in your mind in a young female occurring in the same place? Very good, Dr. Zoha. Herpes comes into mind. What else? There are other options of sore rashes. What are other sore rashes? Can anyone tell me what are other sore rashes? Herpes simplex, chickenpox, very good. Shingles, syphilis, sometimes sore, some not always sore, Dr. Afsha. Shingles, yes. Very good. Very good. Chancre, very good. What else? Sore rashes. Very good. Very important. Impetigo. So impetigo will have particular areas that are affected. So always remember in mind, start with a very basic thing. If it's a recurrent one, then think about whether it's an infection causing like herpes zoster, right? Cellulitis can be a sore rash as well. Chickenpox is a sore rash. Sometimes measles with a superimposed infection is a sore rash. Chronic condition. So if they have mentioned that patient has a chronic condition, think about eczema as well. It's a sore rash. Psoriasis can be a sore rash as well. In kids, age group changes the sore rash differentials. So in kids, contact dermatitis, heat rash. These are the sore rash. Okay, so your look at the options now. So it's a young female having recurrent rashes. Very good, fixed drug eruption. So young female, recurrent rash on the same dermatome, sore to touch, had previous 3 episodes. So we know it's herpes zoster. And then they have given you a picture as well. Sorry, let me just so fluid-filled blisters, herpes simplex. All right. Any questions, guys, from this one? Do you get how we come to the conclusion that this is herpes simplex? Vesicles, very good. Now for the herpes simplex virus, there is a STI guideline. Even though most of the time it's not a sexually transmitted infection, but these guidelines do have those topics covered under them. So let me just open up this link for you. Sorry, it's just taking a bit of time. Be patient with me. Sorry, why is it not herpes zoster? It is herpes zoster. Oh, sorry. Sorry. It is herpes zoster, guys. This is not herpes simplex. Let me just correct this for you. Answer is herpes zoster. It should be coming up herpes zoster. The answer is herpes zoster virus. Now, why not herpes simplex? I will explain it to you guys. So the difference between herpes zoster virus and herpes simplex virus is number one, recurrence. Number two is the location. So herpes simplex virus, type 1 and type 2, right? Type 1 is very commonly in and around mucosa of the mouth, and type 2 is genital associated. Whereas the herpes zoster virus is the virus which has been dormant in a dermatome of the trigeminal nerve or any of the nerve. And then when the patient undergoes any stress in the body, it it causes a recurrence infection in the form of vesical eruption in the dermatome of the body. All right, so we'll go through those. So let's go. Let me just share my screen with you guys to show you how the STI will look like. So this is the STI, Australian STI management guidelines for use in the primary care, but everyone uses it. It's very important for use in general practice. The dermatology department also uses it. And then there's a sexual transmitted infection clinics. They use that for managing the patients as well. Now, if you go through the STIs, there are different STIs mentioned over here. Syndromes have different syndromes which are associated. Different population, when they present with symptoms from either STIs or syndromes, what to do with them. Okay? Is it clear, everyone? So let's go through genital herpes simplex from here. So as I told you, herpes simplex virus type 1 and 2, and it has association with causing vesicles around the mouth and mucosal area, and type 2 is in the genital areas, whereas zoster is in the dermatome, dorsal ganglion. It remains dormant there and becomes activate when a patient gets infection or any sort of stress of the body. Um, it's if the patient is coming with the genital herpes simplex virus, then we know the cause is type 1 and 2. Clinical presentation is that they can have ulceration if it's in the genital area. They can come with painful urination, painful defecation if it's around the urethra and anal region. Because it's itchy at first, ulcers and blisters are formed, and then the skin around that area becomes very itchy. So it can cause fissure in the skin, which leads to pain and soreness. If the patient is pregnant, it can lead to neonatal infection if the patient goes for vaginal birth. Okay. Should we study this from the site? Yes, I would 100% recommend, Dr. Sarah, for you to study all STIs from this site. How do we diagnose it? We just swab it and send it for PCR. That can have HSV type 1 or 2. It will just tell you about it. Management, if it's an initial episode, you can give antiviral for the patient, which is valacyclovir, 500 milligrams. You don't need to remember the dose. You just need to remember what sort of antiviral is used. Recurrent episode, the dosage is a bit different. You have to do an episodic therapy and suppressive therapy. So episodic therapy is for 3 days, suppressive is for 6 months. And in pregnancy, valacyclovir from 36 weeks until birth. Contact tracing is not required in here, but we need to make sure we are giving analgesia to the patient because it's quite sore, lignocaine in the area. Advise them about how to urinate and defecate to avoid the pain from that region. Sometimes it can cause neuropathic bladder because of the pain. That's about it. Special treatment is for pregnancy. So as I said, if a patient has a diagnosis of HSV infection in the genital area during pregnancy, they're recommended to have the antiviral therapy from 36 weeks onward till they have a birth. And if they have active lesions at the time of the birth, then it's advised not to have a vaginal delivery because of the high chances of the neonate getting the infection. All right. So this is the Australian STI management and guidelines. Take a picture of that, and I would advise you to study all the STI related questions from here. All the topics are covered in this wonderful, wonderful resource. All right, let's go back. You just Google it, Dr. Afshan. You can just Google it. It's very easy to find. All right. Are you guys happy how we reached the answer? What sort of things to we focus on? All right. Now, another question from dermatology. Which is the single most appropriate treatment for Trichophyton rubrum toenail infection, which is basically a fungal infection of the toenail, and it's affecting more than 50% of the nail. So very important point here. Option A is oral fluconazole. Option B is oral isofulvin. Option C is oral terbinafine. D is topical clotrimazole. E is topical terbinafine. Now, always remember there is a trick that we have learned in dermatology is that, especially for toenail infection, if it's less than 50% effective, you can try topical therapy first. But if it's more than 50% effective, then you need to go for oral therapy. For Trichophyton rubrum, which is a particular kind of a fungus, the antifungal which is more effective against it is terbinafine. So oral terbinafine is most affected for fungal infection of the toenail more than 50%. Why we chose the oral is because more than 50% of the toenail is affected. If less than 50%, you can try with the topical antifungal first. So your correct answer is oral terbinafine. Now, there are a lot of guidelines I have put over here. You can go to DermNet Z, which is a good source for dermatology, or you can just consult John Murtagh. John Murtagh has very good dermatology topics covered in it with the pictures as well. So if you want to study dermatology from John Murtagh first and then revise it through these guidelines, that would be great. If you just want to stick to John Murtagh for dermatology, you can easily pass your exam from that as well. It's just resources I have put over there. That if you don't want to go through here, you can go through these two as well. And it will be fine. Will these topics be covered during the theory classes, or should we read the guidelines on oral? These topics will be discussed in theory classes, Dr. Ananya. And I will just give you the sources other than John Murtagh, that if you have, you know how there are flashcards? DermNet Z has flashcards. So if you have studied it once from John Murtagh, you can easily revise it through the flashcards of the DermNet Z for dermatology. All right. So treatment for toenail fungus caused by Trichophyton rubrum, it often involves oral antifungals like terbinafine, sometimes topical medication, and nail care. Other options are a PACT therapy, which is a or photodynamic therapy, which is for resistant toenail antifungal infections. And sometimes there is a combination of topical oral therapy, which can be used for patients who are having very bad nail infection and you think that they might require both of them. So medical treatment, oral antifungals is terbinafine, drug of choice for Trichophyton rubrum because it's a dermatophyte. Topical antifungals can be used, but they are less effective, especially when more than 50% of the nail is affected. And the PAC therapy is for patients who are resistant to above of them. Clear, guys? Any questions from here? Would studying the 8th edition be fine for dermatology? Dr. Arshan will provide you guys, for those who are joining our course, they will be provided with a soft copy of the latest John Murtagh edition. And then you guys will study each topic through there. He will go through all, for example, covers the cardiology in 4 to 5 lectures, dermatology in 2 lectures, and he will go through all the topics in John Murtagh for dermatology under the lectures there. Okay. Is it clear, guys? Any questions from the previous question that you have in your mind? You don't need to remember the dosage for this, Dr. Joanna. Doses are not usually asked in the exam. All right. Next one. 27-year-old woman, non-smoker. She suddenly develops double vision, sudden onset. Very important in the question.
Sudden
She
onset.
had an episode of reduced visual acuity. Sorry, I'm just going to mute everyone. It's very difficult to speak when people are speaking on top of me. Sorry, I'm just going to mute all of you guys. If you have any questions, please ask in the chat box. Thank you. All right. So she had an episode of reduced visual acuity in her left eye while she was on holiday. So this is not the first time she had a problem with her vision. She had problem with her vision before, and it happened 18 months previously, where she had a reduced vision, but not complete loss of vision. Um, she has no other significant past medical history. She's quite young as well, not a non-smoker. Which of the following is the cause for her presentation? Now, very young patient, no risk factors, and coming with vision problem. What is the first thing that comes to your mind that you want to rule out in the patient? Very good. Multiple sclerosis. What else? It there should be some other differentials that you want to. Glaucoma in a young patient, less likely. If it's men and he's smokers, if it's a male and he's a smoker, then you should be thinking about other things. What other things should be you thinking about? Temporal arthritis, very good. Thyroid, very good. Myasthenia gravis, excellent. Migraine, excellent. What else? So space occupying lesion, wonderful. Cranial nerve issues as well, which does come under myasthenia gravis and multiple sclerosis. All right, but wonderful. So in a young patient with a sudden onset, also think about very good retinal detachment or vitreous hemorrhage. Vitreous hemorrhage doesn't cause any vision problems. Central retinal artery occlusion or vein occlusion. But if there is no risk factors, those will be at the bottom of your list. Graves' disease doesn't cause sudden onset because it will be a gradual ophthalmopathy that develops in Graves' disease. All right. Now, options are number one, berry aneurysm, number two, cerebral glioma, drug-induced grave disease, multiple sclerosis. So if patient doesn't have any risk factors and they haven't mentioned any drugs, less likely to be Graves' disease and drug-induced. Cerebral glioma can cause, but most common presentation of reduced visual acuity recurrent in a young female is optic neuritis caused by multiple sclerosis. Berry aneurysm could be a cause, but it causes something else. It causes thunderclap headache leading to subarachnoid hemorrhage. So subarachnoid hemorrhage symptoms will be there. All right. Berry aneurysm will usually aneurysms doesn't do anything. They don't cause symptoms unless they burst, right? They can cause headaches here and there, but they don't cause symptoms unless they have ruptured. Cerebral glioma will also doesn't cause symptoms suddenly. They cause headache. They will cause raised intracranial pressure symptoms like um, doubling of the vision, but both eyes will be affected. Or whereas the glioma is, if it's in the left hemisphere, mostly it will be affected by that. All right. But it will have pressure symptoms as well, headaches, nausea, vomiting early in the morning, blood pressure problems, and then vision problems, of course. Is it clear, guys? So your answer is multiple sclerosis. Everyone agrees here? It's quite well written in your Janmurta. And if you want to have a go through, we can go through quickly through the topic in RSCGP. RSCGP has described this as well quite well. Let me share my screen with you guys. So this is an article written by RCGP. I would recommend for you guys to study the topic from the John Murtaugh, but this is something just I have put over here for review only. It's the most common chronic debilitating disease of the central nervous system in young adults. That's why we went for multiple sclerosis instead of cerebral glioma. Cerebral glioma will have other features as well, but if you have vision problems, you're a young patient, you should, and it's a recurrent problem, you have ruled out every common thing like eye infections, problem with the lids, you have ruled out any vision problem like short-sightedness, long-sightedness, then you should be thinking about multiple sclerosis. Etiology, environmental and genetic factors. Some some studies have shown that Epstein-Barr viruses and smoking, but not a lot of evidence is out there to back up this studies. Epidemiology is that it's quite common in young adults. Mean age group is mid-30s, so very young. Natural history. So usually patient will have symptoms of neurological disturbance developing over days to weeks to months. Could be an isolating neurological syndrome or could be a number of neurological symptoms that they can present with. Could be optic neuritis, which is the most common symptom presenting, um, associated with the motor and sensory deficits, or could be brain stem syndrome, which will cause problems with vision, problems with speaking, problems with your coordination, and multifocal abnormalities. Now, because it's a demyelinating disorder, it's a relapsing remitting. So, patient is treated with steroids when the patient is having flare up of the disease, and when the symptoms get controlled, they go into a relapse. But then again, it can get triggered again. It is also secondary progressive type as well. Patient sometimes from relapsing remitting course develop a progressive course of multiple sclerosis where they don't have remittance anymore. They continuously progress towards the worst prognosis. And then primary progressive as well. So symptoms, optic neuritis, which can be pain on eye movement, blurred vision, can be monoocular, can be biocular as well, cerebellum unsteadiness, ataxia, gait problem, nystagmus. If the spinal cord is involved, then you will have motor and sensory deficits. Brain stem is involved, then you can have doubling of the vision. If the bowel bladder is involved, constipation, urinary frequency, urge incontinence, erectile dysfunction. The other differential for multiple sclerosis we have already discussed in our questions. Management is that we give steroids and then other drugs, disease modifying treatments are available, which is interferon alpha and beta, glatiramer acetate, these are all T cell um, anti-T cell drugs, which is basically chemotherapy. Patient does become quite immunosuppressant when they are on them. Treatment of acute relapses is IV PRED. We've talked about it. And then you can have symptomatic management in this as well. So for spasticity, you can use baclofen, diazepam, dantrolene. For seizures, carbamazepine. For fatigue, amantadine, like in Alzheimer's. For tremors, you can use clonazepam, propranolol, carbamazepine. Urgencies, oxybutynine, propanthyline. Amitriptyline, and for erectile dysfunction, sildenafil. So these are all first line treatment, second line treatment, third line treatment, and then symptomatic management. And in pregnancy, you can't give chemotherapy if the patient wants to have the baby because of the teratogenic effect. The only one that they have listed is these ones because pregnancy reduces the disease activity, especially in the third trimester. Prognosis is not very good. But if it's detected early, treated early, then it's a good prognosis. All right. So just a touch up on the topic itself. The article, you need to have a look whether the article is updated. Usually it's not published every year. That's why I've asked you guys. You can study it from John Murtagh. It's quite well written there. All right. Any question, guys? So somebody has asked me what is Uthoff's phenomena. So Uthoff's phenomena, it's a temporary worsening of the symptoms in multiple sclerosis. It's a process where the body temperature increases, like external factors like weather, fever, exercise, and it can lead when the body temperature changes, the vision changes. That's Uthoff phenomena. Basically means short circuiting when the body is heated up. All right. This is not a guideline, guys. This is just an article. Guideline of multiple sclerosis, it's quite big. You can't go through it in a class. This was just to give you a view of what symptoms they present, which part of the nervous system is affected by the demyelinating disease, and what therapies are used, just to give you an idea. John Murtagh has quite good explanation about multiple sclerosis. All right, now similar question, but with a little bit of tweaking. So the answer is changed because of that. 35-year-old man, non-smoker, sudden onset of severe headache and double vision. Right pupil has become fixed and dilated. Which of the following is the cause of his symptoms? Perianeurysm that has ruptured, cerebral glioma, drug-induced, Graves' disease, or multiple sclerosis. See how changing a bit of the symptoms and the wording has changed the whole diagnosis. So what is the answer here? It's berry aneurysm that has ruptured and led to what has berry aneurysm caused? Subarachnoid hemorrhage. Berry aneurysm rupture leading to subarachnoid hemorrhage because it's a sudden severe headache and double vision with the fixed dilated pupil. Very good. Everyone agrees the answer is this? Any questions or any query from here? Thunderclap headache is particular for subarachnoid hemorrhage. Now, this is from SA Health and it's an emergency medicine guideline. sorry, New South Wales. So let's go through that. Let me just share my screen with you guys. Are you guys able to see the screen? Okay, let me just enlarge it a bit for you. So subarachnoid hemorrhage can be asymptomatic, and the patient who is asymptomatic would present with minimal headache with mild nuchal rigidity. And then there's moderate and severe headache with nuchal rigidity, drowsiness, confusion, stupor, moderate to severe hemiparesis, deep coma, decerebrate, rigidity, moribund appearance. So these are the severity of the symptoms of subarachnoid hemorrhage. How do we assess? Classically, worst ever or sudden onset should put you on red alert that it could be a subarachnoid hemorrhage. Can be brought on by the Valsalva exercise. A good response to analgesia does not exclude subarachnoid hemorrhage, could be a small one that can lead to a big bleed later on. Examination can be normal because it develops over time, right? Focal neurological signs will be there: neck stiffness, photophobia, pupillary signs from raised intracranial pressure, change in the level of consciousness, so altered level of consciousness, agitation, fever because of the intracranial hemorrhage. Investigation. So the first thing, what is the first thing that you're supposed to do in a patient who has subarachnoid hemorrhage and you have a high suspicion of it? What is the first thing that you do? You do a CT scan of the head, non-contrast, right? And sometimes when a CT scan is negative, within the 6 hours, a decision is made with the help of a neurologist to do lumbar puncture, which can show xanthochromia, meaning blood in it. But CT scan, non-contrast. Management is primary survey, so we manage airway, breathing, circulation, disposition, exposure, and immediate resuscitation, including the oxygen, IV analgesia, fluids, and medications to decrease the intracranial pressure. All right? Okay. Let's come back here. Any questions from this question, guys? Any questions from this question? All good? Everyone agrees with this? All right, let's move on. 48-year-old woman has transitory double vision towards the end of most days. She smokes 10 cigarettes a day. She has vitiligo and hypothyroidism. Which of the following is the possible cause for her symptoms? Now, the symptoms and age and risk factors have changed again. So, option A, perianeurysm. Option B, cerebral glioma. Option C, drug-induced. Option D, Graves' disease. E is myasthenia gravis. So, excellent. Everyone has come to the conclusion that it's myasthenia gravis because it's a middle-aged female. Doesn't matter, can be a male, can be a female, has transitory, meaning it goes and comes, doubling of the vision, but it's mostly at the end of the day. It's typical for myasthenia gravis symptoms to occur at the end of the day because of fatigue. Smoker, risk factor. Vitiligo and hypothyroidism indicates that she has autoimmune disorder which is also causing problems with thyroid, problems with skin as well. So think about an autoimmune disorder related to that. We know it's not berry aneurysm. We know it's not cerebral glioma because cerebral glioma will have symptoms in the morning. She's not on any drugs. They haven't mentioned any drugs, so we can't say it's drug induced. This is not grave disease because she has hypothyroidism. If she was on thyroid medication, you can think about it, but less likely for medications to cause ophthalmopathy. The Graves' disease, autoimmune disease, will cause ophthalmopathy if it's untreated with the antithyroid drugs. So the correct answer is myasthenia gravis. Everyone agrees with that? Any questions from here? All right, let's go through this topic very quickly. It's again quite well written in your John Murtagh. I've just taken this resource to go through the topic very quickly with you guys. All right, let me just share my screen with you. Are you guys able to see it, the screen? All right. So muscle weakness that increases during period of activity and improves after rest. So it will be more pronounced after having a very active day during the end of the day. Muscles of the eye and eyelid movements, facial expression, chewing, talking, swallowing are most commonly involved. So it's a ascending paralysis from head to toe, not from toe to head. What's the example of the it's a descending paralysis. What's the example of the ascending paralysis in an autoimmune disease? Guillain-Barré syndrome. Very good. Um, Myasthenia crisis may be triggered by infection, fever, emotional stress, or adverse reaction to a medication. It's an autoimmune disease where the antibodies are formed against the body's transmission of impulse system across the muscles. How do you diagnose it? Do you do serology for the um, antibodies against those muscle synapses? Treatment, it's to treatment is basically you do, sorry, I just had a glitch. Patient is given medications to control the muscle movement, and sometimes the antibodies are removed from the bodies. So the best treatment is they do IVIG and then they do plasmapheresis. Okay? Steroids are also given, but plasmapheresis and IVIG are the main treatment. It has a very good prognosis. All right. Any question, guys? Acetylcholinesterase antibodies. Investigation is the serology. Pyridostigmine is not given all the time. It's a drug that is given by the specialist. Steroids is the drug that we give. Pyridostigmine is only given for symptom relief, but steroids are given for disease management. And then plasmapheresis and IVIG is for disease management. So if they're asking for symptom management, then you can consider pyridostigmine. But if they're asking for disease management, steroids and plasmapheresis and IVIG. All right. Clear, guys? Investigation is we test the serology for the antibodies. Okay. Dr. Dilmayer, for emergency medicine, which guideline should we follow? Dr. Arshan will go through emergency medicine, and for emergency medicine, good website to go through is the New South Wales emergency guidelines for quick revision. But Dr. Arshan he covers emergency medicine quite good. All right. Next slide. This is from genetics, my least favorite topic in all of the exam. A couple have just undergone screening test for sickle cell disease in pregnancy, and both are found to be carriers. What is the chance of their child having sickle cell disease? 0%, 25%, 50%, 75%, or 100%? So can anyone tell me sickle cell disease, is it autoimmune recessive or autoimmune dominant? Very good. It's autoimmune recessive. So let me share with you guys. I'm very poor at describing this, so I'm just going to share this with you. So it's an autosomal recessive disorder. If both parents are carriers, there's, for example, parent one and parent two are having the gene with the sickle cell disease, the red ones, then there's a 25% chance that their child will have a disease, 50% chance that the child can become a carrier, and 25% chance of the child not being affected. So your answer is 25%. Very good, Dr. Hussain. It's Punnett square that we do, but I just memorized this thing for the exam. I'm not very good at describing this. I'm not very good with the genetic traits. But yeah, these questions do come in your exam. And if you know how the trait works, it's easy to get the marks in these questions because there's no wrong answer. There's only one right answer in here. All right. Old lady, 64 years of age, was brought by husband due to forgetting things. She sees a man outside her house, which husband reported not to be there, so she is having visual hallucinations. Um, Examination, she takes very small steps and has tremor. So on top of having dementia and visual hallucination, she's having neurological problem as well. Which one of the following is the provisional diagnosis? Now, this is geriatric medicine, and they're asking you questions about dementia. There are various types of dementias as listed here, associated with Parkinson disease, Lewy body dementia, Alzheimer's related, and then vascular dementia. This lady is having some symptoms of Parkinson disease, but she's having visual hallucination. Visual hallucination is typical in which sort of dementia? Does anyone know? Lewy body dementia is described as visual hallucination dementia with some symptoms of Parkinson disease. So this is typical of Lewy body dementia. Parkinson's disease will have typical Parkinson disease symptoms and dementia. They don't have visual hallucinations unless they are having medication that is causing visual hallucinations. Alzheimer doesn't happen in this age group and it doesn't cause visual hallucinations. Vascular dementia doesn't cause visual hallucinations and doesn't cause Parkinsonian symptoms. It causes dementia associated with blood pressure problems. Okay? Is it clear, everybody? So Lewy body dementia is typical dementia that presents in elderly with dementia symptoms of forgetfulness, visual hallucinations, and symptoms of Parkinson's disease as well. So your answer is Lewy body dementia. So Lewy body dementia, abnormal clusters of protein are formed inside the cerebral cortex, and inside the midbrain and brainstem. So patient will have disorientation, shortened attention span, short-term memory loss, verbal communication, and visual hallucinations. Parkinsonian symptoms such as tremor and muscle stiffness. Vascular dementia is because of the blood pressure problems. Dementia is JM, John Murtagh. Vascular dementia is caused by blood pressure problems. So dementia, verbal communication, short-term memory problems, sometimes seizures will be there. Physical symptoms of stroke will be there. Frontotemporal dementia, it's the progressive disease which affects the frontal lobe and the temporal region. Patient will have behavior problems, inappropriate behavior, loss of empathy and insight, using abusive words, unable to maintain hygiene, inappropriate use of language, those sort of things. If you're having in your question, think about frontotemporal. And then Alzheimer's is it's early age dementia. Okay. All right, guys, let's take a 10-minute break and then I'll come back and we'll finish this class. 10-minute break, please. Go and relax, and then we'll do more brainstorming after 10 minutes, okay? Previous box, here you go. Take a picture of this. You can also Google this. It's, I think it's MD journal that I have taken this picture of. All right. All right. I'm just gonna stop the share here. I can't give you a good answer to that, Dr. Mukta Thakur, where to read genetic topics from, but I've only studied it from John Murtagh. All right. 10 minutes break, everyone. I'll see you guys after 10 minutes. All right, everyone, welcome back. Let's start again. Let me share the screen with you guys. Are you guys able to see the screen? All right. Let's start again. 35-year-old woman stopped the combined oral contraceptive pill 6 months ago because of her increased blood pressure. Her periods haven't returned. She feels generally tired and has put on weight. Pregnancy test is negative. Fasting blood sugar is 9.2 millimole. What is the single most likely diagnosis? She's having anemia. She's having chronic active hepatitis. She's having celiac disease. She has contracted Cushing disease, or it's hypothyroidism. So she stopped the oral contraceptive pills because she had high blood pressure. So her symptoms are high blood pressure, amenorrhea, obesity, and blood sugar levels are high. So it's a multi-system problem she's having. We know it's not anemia. We know this is not chronic active hepatitis. We know this is not celiac disease because there is no deficiency she's having. Now, it's either D or E. What is the most likely diagnosis? Does hypothyroidism cause amenorrhea or menorrhagia? Very good, Dr. Hasnan. Most of the time, Dr. Afshan, hypothyroidism causes menorrhagia. Okay, so this stem points us towards Cushing disease. All right, excellent. Everyone agrees with this? Your answer is Cushing disease. So this woman has high blood pressure, amenorrhea, tiredness, weight gain, and hyperglycemia, all secondary to Cushing disease. Hypothyroidism, most of the time, does not cause any problems with the blood sugar levels, but hypothyroidism does cause blood pressure problems, periods problem, tiredness. Yes, you will get reference rate in an exam, but hypothyroidism, most of the time, they have menorrhagia symptoms instead of amenorrhea. All right. Next question. I'm not going to go into detail of that because we have already discussed in different options what is the accurate answer. All right, this is related to pediatric age group, and this comes in your exam quite often, this topic. 14-year-old boy came with mother to your clinic with concerns that his height percentile has dropped from 25th to 10th. Weight is still at 25th percentile. Patient has Tanner stage 2, otherwise okay. What investigation to diagnose condition? Tanner stage 2 is pubertal staging. So do hormone levels, FSH and LH, do testosterone level, do X-ray bone age, X-ray for bone age, or do pituitary hormonal assay. Initial investigation, guys. So this wording comes in your exam quite often. What is the investigation to diagnose the condition? What is the investigation we do initially? So initial investigation is the first investigation you would do to rule out common things. And investigation to diagnose the condition is the gold standard diagnostic investigation. So here they are asking you not the diagnostic, but the initial investigation. Patient is having problems with the height. They're having tenor stage 2 at 14 years of age. So we are thinking something is going on with the growth, right? So the first thing to rule out whether patient is having pubertal problems or growth problems is we do assess bone age with the help of an X-ray. Hormones are tested afterwards. All right, let me share with you guys this. You can study it from here, but in JM it's quite well written. Now, for short stature associated with genetics or associated with the hormonal problem, why this is coming weird? My slide is coming quite weird. Give me 1 second, guys. I will open this slide in my coming quite weird in the slide. Sorry, please bear with me. I'm just trying to find this one because it's not coming up quite rightly in there. Let me see. All right, let me just remove this image because it's not coming quite rightly in my slide. And I will put another one. Okay. Give me 1 second, guys. All right. Are you able to see this one? Yes. So our patient was coming with tennis stage 2 at 14 years of age. So the patient is having problem with pubertal problems. So when you open up tenor stages in your Google, you will see what stage represent what sort of age they might be having. So tenor stage 2 should be present at least 9 to 10, whereas tenor stage 4 and 5 is present at 14 years of age. So the patient is having pubertal problems and they're concerned with the height as well. So assessing a child with a short stature, you go through a different algorithm to decide whether patient is having height problem, growth problem, or whether there's something genetically going on, or whether there's something going on with the pubertal pathway as well. So when the height is below the third percentile, or there's the velocity is not normal, then you do growth assessment. We do comprehensive physical examination. They have given you 10 staging problems. First investigation to do is the bone age study, which is the bone scan to see whether the bone age is according to the on the x-rays according to the age of the patient. Then we do blood tests to see whether patient is having deficiencies that is causing problems. For example, liver function test, full blood count, ESR, iron studies, electrolytes, urea, creatinine, calcium, magnesium, phosphate. And then we do the growth hormones like growth factor 1, growth factor BP3, luteinizing hormone, FSH, estrogen, testosterone. And then you do celiac disease investigation to see whether the growth deficiency is caused by that. When you see on the bone age that it's less than that for that age group, plus on the comprehensive physical examination, you've seen that the puberty is delayed, then you can say that it's a constitutional delay of the puberty. When you see there is some medication that is causing deficiencies, or it's a celiac disease causing malnutrition problems, deficiency problems, or there's malnutrition, you address those causes. When there is a growth hormone deficiencies, you refer for testing and evaluation of that. When the height is consistent, growth velocity is normal, and the child's height is consistent with the parental height, average of it, you just reassure the parents. When the child's height is not normal and you see dysmorphic features on physical examination as well, then we go for karyotyping. Constitutional delay is like normal delay. The body is taking a little bit of time to go through puberty. Okay, that is constitutional delay. Body catches up with the puberty. It doesn't mean that puberty is not going to come. It just means it's having a bit of a delay. Now, when the height is not consistent with the parent's average height and there are dysmorphic features of the child that you're concerned that this might be something genetically related, then you do karyotyping or you refer to the genetic services. So the first investigation to do is the bone age study, which will give us an idea whether the growth is getting normal or not according to the age. Does that make sense, guys? Is it clear, guys? So when mid-parental, for example, what is the parent's average height on mom's side and on the dad? What is the average height? All right. Now, growth is very important topic in pediatric, and a lot of questions will come from the puberty, growth, constitution delay, growth hormone deficiency related delays, celiac disease related problems. Very, very important for your exam. All right, another similar question. But look at the symptoms. So 50-year-old women recently diagnosed with high blood pressure. Now she's coming to you with complaint of pain in knees. So she has hypertension. Now she has bone pain in her knees. Okay. She also feels tired. Memory is also affected. She lost her appetite. So there is anorexia and feels nausea most of the time. urine analysis is normal. So what is your likely diagnosis? So there's a lot of symptoms happening. Blood pressure, bone pain, tiredness, memory issues, anorexia, nausea. So number 1, chronic fatigue syndrome. Number 2, chronic renal failure. Number 3, celiac disease. Number 4, Cushing's syndrome. Number 5, hyperparathyroidism. So what is the answer? You guys give me answers and then we'll go through what is the correct answer. There are a lot of symptoms she's presenting with. So we'll try to figure out whether these symptoms fit any of the syndromes or the diseases mentioned in the question. Let's go through one by one. Chronic fatigue syndrome. Chronic fatigue syndrome will just present with tiredness. They will present with tiredness at the start of the day, tiredness at the end of the day, muscle pain more than bone pain. Sometimes memory issues, but not blood pressure problems. It could be something that can happen with the chronic fatigue syndrome, but not because of it. And sleep disturbance is very common with chronic fatigue syndrome. Headache is common with chronic fatigue syndrome. Dizziness is common with chronic fatigue syndrome. Lightheadedness. These are the symptoms most common with the chronic fatigue syndrome. So is it chronic fatigue syndrome? No, it's not. Chronic renal failure. Does patient have renal failure with a normal urine analysis? They have given you a very big clue over here. Urine analysis is normal. Do patients with the kidney problems have normal urine analysis, especially chronic renal failure? No. What is the urine analysis of a chronic renal failure? Can anyone tell me? Proteinuria is there. Well done. Urine albumin to creatinine ratio is very low. Sorry, elevated. Hematuria can be there. Very good. Waxy crystals, EGFR is low. If EGFR doesn't come in urine analysis, it's urea electrolytes and creatinine. There's a kidney renal function, but albumin to creatinine ratio is high. So we know urine analysis is not normal. So this is not, even though the symptoms are that of a chronic renal failure, they have given you a big clue that this is not chronic renal failure, right? Everyone agrees with that? All right. Celiac disease. Now, celiac disease, does it present with bone pain, tiredness, memory, anorexia, nausea? But mostly it will present with malabsorption and nutritional deficiencies, right? And celiac disease in 50-year-old will present with bowel problems, rash on the body, thyroid problems, anemia problem, glossitis, neuropathies because of the vitamin B12 deficiencies. Bone pain will be there, but malabsorptive symptoms will be there. So yes, other autoimmune diseases will be present. This is also not Cushing disease because in Cushing disease, yes, it is presents with high blood pressure and pain in knees. But in Cushing syndrome, we have obesity. We don't have nausea and anorexia. Do anyone know what is the symptoms of hypercalcemia? There is a very famous kind of like a proverb used for hypercalcemia associated with hyperthyroidism. Very good. Bone moans, groans, and psychiatric tones, right? So these are the symptoms of hypercalcemia associated with hyperparathyroidism. Everyone agrees with that. So high blood pressure because of the hypercalcemia, bone pains, tiredness and fatigue. It does cause psychiatric moans, which is memory is poor, nausea, vomiting, abdominal groans. All right. So this is hyperparathyroidism, hypercalcemia related hyperparathyroidism. So hypercalcemia, high parathyroid causes high calcium in the blood. That causes renal stones, leading to renal colic, polyuria, renal insufficiency, causes bone pains, fractures, osteoarthritis, fibrosa cystica, which is a disease associated with hypercalcemia of the bone, chronic disease if it is left untreated. GI, it causes nausea, vomiting, ulcers, and pancreatitis if left untreated. Muscle weakness, which causes tiredness. Neuropsychiatric overtones is lethargy, confusion, coma, dementia, or memory loss. And then cardiovascular problems like high blood pressure, hypertrophy, arrhythmias, and deposits leading to cardiomyopathy and heart failure. Agreed, guys? Any questions from here? All good? Okay. Moving on. We have a middle-aged man, 45 years of age, who came to see you in clinic. So this is a GP setting they're talking about. Now he's having concerns of breast enlargement bilaterally. It's a male with the bilateral breast enlargement. He takes spironolactone and digoxin and has strong family history of breast cancer. So he's on a medication that can cause gynecomastia and also have family history positive as well. What is your next step of management? So coming with concerns of breast enlargement, you should, and they're asking you the next step, which is the initial management basically. Stop digoxin, stop the spironolactone, do fine needle aspiration or cytology, do ultrasound of the breast, or do a clinical examination on the patient. Okay, so we're having mixed answers. Now, always remember for any of the breast mass, enlargement, whatever question related to breast, there is a triple test which is followed, always. All right? Is anyone aware of this? So you do history, then you do clinical examination, triple assessment, very good, and then you do imaging. So he's coming with the breast enlargement. We got the history that he has strong family history. He's on certain drugs. Now, what is the next step of triple assessment? Clinical examination. Even if you look at it from a very basic point of view, they're asking you the next step. You have taken history. What is your next step after history? You do examination on the patient. You assess whether the bilateral enlargement is uniform or is it unequal, or whether there is any nodularity to it, or whether there is any mass field to it, or whether there is any lymph node involvement. Then you go for imaging. 45 years of age in males, we do ultrasound, right? We don't do mammography in males, but we do ultrasound. And then on the findings of the ultrasound, you refer the patient for fine needle aspiration cytology or core biopsy. So your correct answer is we will do a clinical examination on the patient after taking a history. So the history has been taken. Your next step in triple assessment of a breast-related problem is to do clinical examination, and then you can organize an imaging based on your findings. Is it clear, guys? Everyone agrees with this? Next step of management. Management doesn't mean treatment, Dr. Zahid. Management means what is your next step in managing this patient? How would you proceed? Dr. Tashifa, if they said you have done examination, what is the next step after examination? You would organize ultrasound of the breast. If they asked you what is the next step for treatment, then you can say you can stop the spironolactone and see whether patient is having gynecomastia because of it. But in breast, always do triple assessment first, and then you can do, because you have ruled out all the things. He has strong family history of breast cancer. Would you just stop the medication to see it goes away, or would you just take it very seriously to rule out breast cancer in this male? It's very simple. Triple assessment is designed to make sure that you're catching these patients early on so that they can be treated. Imaging means ultrasound. Imaging, radiology, basically. Okay. All right. Key steps in assessment: medical history and physical examination. About the duration, presence of pain, tenderness, any nipple discharge, physical assessment, asymmetry, signs of inflammation, lymph nodes, distinguishing between true gynecomastia and pseudogynecomastia, whether it is true enlargement of the breast tissue or just fatty deposition, because it can be fatty deposition if it's an obese patient. Then we make sure there are no other, like in our patient, there were medications we know, and we knew that the patient was having strong family history. Then we do diagnostic test. Here we don't do blood test, we do imaging first, ultrasound and mammogram. In younger men, ultrasound is preferred. Mammogram is for older men above 50 and in females above 40 years of age. Females, less than 40, we do ultrasounds. Above 40, we do mammography. Males is different. Less than 50, ultrasonography. Above 50, mammography. And then biopsy based on the imaging results. All right, very easy questions, very commonly asked questions from population health in your exam. They do ask about what sort of pathogen is involved in causing what sort of virus, infection, sorry. A 7-year-old girl has a fever associated with a sore throat and loss of appetite. She has small red ulcers in her mouth and itchy spots on her hands and soles of her feet. What is the likely virus causing her symptoms? Option A, Coxsackie virus. Option B, herpes simplex. Option C, measles. Option D, parvovirus. Option E, varicella zoster virus. Can anyone tell me? So this young patient is coming with fever. She had some sore throat. Now she's having lesions in her mouth, hands, and feet. So this is very good. Hand-foot-mouth disease. And hand-foot-mouth disease is caused by Coxsackie virus. So this is something that you have to cram. It's not something conceptual, I'm sorry, but you have to really memorize what is the virus causing which disease. So this is Coxsackie virus. Let me show you guys the picture of hand-foot-mouth disease. Okay. Have a look at the slide. So this is the lesions. It's like blistery lesions on hand, foot, mouth, in the palms as well, on the soles like this. Sometimes they're sore, sometimes they're not sore. So this is hand-foot-mouth disease. Very common in daycare going kids here. All right. You can study it from RCH, you can study it from Dermatology, you can study it from JM. All are written quite well. All right. Next question. All right. Patient 55 years old male presents to GP clinic with bilateral gynecomastia. So one of the symptoms is that. Parotid swelling. The second symptom, scrotal swelling. Past medical history shows that he is chronic alcoholic and diabetic. What is your provisional diagnosis? He's having liver failure. Patient is having testicular cancer, breast cancer, parotid tumor, or melanoma. So patient is having stigmata of symptoms. Bilateral gynecomastia, parotid swelling, scrotal swelling means there is edema in the body. Very important clue they have given you that patient had chronic alcoholism. Chronic alcoholism leads to chronic liver disease. Very good. Patient is having liver failure basically. Testicular cancer can present with scrotal swelling, can cause gynecomastia, but they don't cause parotid swelling. Breast cancer can cause gynecomastia, parotid swelling, but it's not related with the scrotal swelling. Parotid tumor can cause, it's just a parotid swelling. It doesn't cause gynecomastia and scrotal swelling. Melanoma can cause parotid swelling, gynecomastia, but it doesn't cause scrotal swelling. These three things doesn't come together in all of this. It's just liver failure that has all the stigmata together. All right. Initially, it's testicular atrophy, but scrotal edema. So scrotal swelling is ascites, and then it leads to scrotal edema. All right. Have a look over here. So altered, these are the symptoms. We all know all the stigmata symptoms. So caput medusae, hepatomegaly initially, and then cirrhosis, tachycardia, splenomegaly, ascites, scrotal edema, hypogonadism, ecchymosis, pedal edema, jaundice, palmar erythema, spider nevi or angiomas, esophageal varices, rectal varices can also happen, altered consciousness, jaundice, muscle wasting, transient hallucination, parotid swelling because of chronic alcoholism, and then gynecomastia. All right. Chronic alcoholism causes parotid swelling. Liver disease, particularly alcohol-related cirrhosis, can cause parotid swelling through a condition called salginosis, which is a non-inflammatory and non-neoplastic enlargement of the salivary glands. This swelling is usually bilateral and painless and is associated with metabolic conditions like liver disease, diabetes, and malnutrition, but it's caused by alcohol in those diseases. Clear, guys? Any question? Now, this is a very, very easy question. Sometimes in exams, you'll be like, oh my goodness, what is the answer to this? But use your basic logic, because sometimes easy questions we miss because we are trying to think very complex things in there. In exam, start with the basic things. Start with the common things and then move towards the complex conditions. They don't always ask about the complex conditions. They ask about basic knowledge. So 80-year-old adult patient who lives alone, refuse Meals on Wheels, which is like basically delivery service, is coming to you and complaining of constipation but doesn't have rectal bleeding. Weight is okay, abdomen and rectal examinations are okay, and she is otherwise well. What is the cause of her constipation? Alzheimer's, carcinoma of the colon, diverticular disease, hyperthyroidism, or just poor fiber intake? See how she is refusing to eat meals. So if she doesn't have good oral intake, poor fiber intake, she will go and have constipation. With the carcinoma of the colon, she will either have rectal bleeding, she will have tenesmus, she will have some symptoms, weight loss. Diverticular disease also causes abdominal pain and bleeding whenever they open their bowel. Hyperthyroidism, weight will be increased. Alzheimer's disease patient will be, usually Alzheimer's doesn't cause any problem, but it just causes patient to have memory issues and hygiene issues, but poor fiber intake is the problem here. So your correct answer is poor fiber intake leading to constipation. All right. Common causes of constipation in the elderly, it includes medications, diet, lifestyle, medical conditions, and age, obviously age as well. So in our patient, because she's refusing to eat, diet is the most common cause for her constipation. Everyone agrees? Any problem in that question? See how basic information can lead to a correct answer as well. All right. Next question. A 67-year-old man has nocturia and post-micturition dribbling, which is interfering with his sleep. Clinical examination investigations are keeping in with that he has benign prostatic hyperplasia with the minor degree of prostate enlargement. Which is the most important initial treatment? Option A, duloxetine. Option B, finasteride. Option C, oxybutynine. Option D, solifenacin. Option E, tamsulosin. Very easy question. They have asked you in a patient who is having lower urinary tract symptoms associated with benign prostatic enlargement. What is the initial treatment? So we all know it's option E. Very good. Let me go through this a little bit so I can discuss about other regimes which are used for treating benign prostatic hyperplasia causing lower urinary tract symptoms. Yes, it's short acting and it doesn't cause any problems and it will release symptoms. And it is the initial treatment used for BPH as well. It's second line. Okay, let me show you guys. Are you guys able to see the screen? AGP, AJGP. All right. So what are the symptoms of benign prostatic hyperplasia? You will have lower urinary tract symptoms. You need to have differential diagnosis. It could be infection, it could be neoplasia, it could be neurological conditions. So you need to have a broader perspective as well. Important history and examination. So you need to ask about the urinary symptoms like incomplete emptying, frequency, intermittency, urgency, weak stream, straining, nocturia, and how it has affected the quality of life. And this is a scoring system that we usually do. It's called IPSS, which is International Prostate Symptom Score. And if the score is high, then we have a high suspicion that it could be prostate-related issues. After taking good history, ruling out any other causes, we do physical examination where we make sure that we are checking the genital areas. Also, for benign prostatic hyperplasia, it's very important to do a digital rectal examination to rule out whether it's just a benign condition or if there is any malignant features of the prostate as well. Like prostate cancer is very nodular, prostatitis is tender, and constipation can also lead to lower urinary tract problems. Now, investigation for BPH, very important for your exams. First, initial investigation is urine analysis to rule out infection, hematuria, or glycosuria that can cause lower urinary tract symptoms. Then you do blood tests and see the renal function to see whether because of the kidneys there's problems with the urine. And then we do urinary tract ultrasound that includes your bladder, your kidneys, your ureter, and your prostate. And then prostate specific antigen to rule out prostatic cancer in elderly males. Management, medical therapy. It's from the alpha adrenoreceptor antagonist combined with the 5-alpha reductase if there is no improvement in symptoms from the alpha adrenoreceptor antagonist. So tamsulosin, sildenafil, terazosin. Tamsulosin is the most commonly used. Terazosin is cheaper, they're commonly effective, but they should be warned about the side effects before starting, but this is very short acting and has fewer side effects. Then we have 5-alpha reductase inhibitors that can be used in conjunction to the first ones if the patient is not having a good response. All right, phosphodiesterase inhibitors can be used, and then if the patient is not responding to combination therapy, then we refer to the urology for surgical management. And these are surgical management that is given over here. Clear, guys? Just gonna jump back really quickly. Tamsulosin is used as a first line, Dr. Sayed.
Is single ingredient serums are best or serum that contain combination of multiple ingredients?
If you want to ask a question, I would advise you please write in the chat box. Okay, tamsulosin will only relieve symptoms. Yes, it's a symptomatic relief. Finasteride will be a second line option if the patient is not responding to tamsulosin. If it's a minimal symptoms, sometimes if the patient is having very bad symptoms that is affecting their quality of life, some doctors do start combination therapy, but you have to remember this is your exam. They want pet answers. So start with the first line, then move on to the second line. Okay. Tadalafil more frequently used latest guideline. No, it's not the tadalafil, it's tamsulosin, the alpha adrenoceptor antagonists. All right. And then the second line is the 5-alpha reductase inhibitors, dutasteride or finasteride, like Dr. Said has said. Combination therapy of the alpha and the reductase inhibitors, blockers and inhibitors. If they are not helping, then we move on to phosphodiesterase inhibitors. Especially, you can use phosphodiesterase 5 inhibitors if they are having ejaculation problems as well. But remember, you have to counsel them that the alpha blockers will cause some ejaculation problems. If they are having problems not related to prostate, sure, you can start them on these medications. But these are third line medications for treatment of BPH related lower urinary tract symptoms. All right. Next question, guys. Okay. A man 65 years of age is presenting with metastatic bowel colon cancer, and he's taking oxycodone for pain, which is basically an opioid. He's on palliative care pathway for bowel cancer management. He came to emergency department with 1 week of not being able to pass wind or feces. What is the cause of his symptoms? Large bowel, small bowel, obstruction, oxycodone-induced constipation, or paralytic IBS. So he's not able to pass wind or feces. Absolute constipation. What is the symptom? Which disease is more consistent with absolute constipation? It's large bowel obstruction. It is because of oxycodone, fecal impaction leading to large bowel obstruction, leading to absolute constipation. So this is large bowel obstruction. You can't say it's constipation because this is not constipation. This is absolute constipation. Constipation means that you're able to pass flatus. Absolute constipation means flatus and feces both are unable to pass through the bowel because of blockage of the large bowel. So this is a symptom of the large bowel obstruction. Everyone clear on that? If the patient presented with nausea, vomiting, but able to pass wind and feces, but having abdominal pain, you will say this is small bowel obstruction because nausea, vomiting after eating anything, and then abdominal pain with it, Think about small bowel. These are symptoms associated with small bowel, but large bowel is absolute constipation. Paralytic ileus will have mixed features of large and small bowel. Clear, guys? This is large bowel obstruction. This is the comparison of symptoms between large bowel and small bowel. So in small bowel, you will have pain because small bowel are present in the mid of the torso, so mid-abdominal pain, whereas large bowel is in the lower part of the tummy, especially in right iliac fossa, left iliac fossa, you'll have pain there. Small bowel is colicky pain, whereas large bowel is glutinous pain or peristaltic pain. Vomiting is the early symptom of small bowel obstruction because it's very close to the stomach, whereas the late symptom of large bowel. Distension, very severe in large bowel, whereas in small bowel, it's not very common. Constipation or absolute constipation, marked in large bowel obstruction. Okay? Any questions from the last one, guys? Happy with that? All right. Next question. 8-year-old child is going to camp. He has a history of enuresis, meaning a 8-year-old child has bedwetting problem. Otherwise, patient is normal. What advice to give parents to avoid accidents during the trip? Desmopressin nasal spray. Advise fluid restriction at evenings before going to bed. Do not go to camp or give desmopressin tablet. Now, enuresis in an 8-year-old child is a problem, and patient wants to go to the camp, and the parents are coming to you for advice about how to avoid accidents. So we need treatment. We don't need advice about, oh, don't drink water. This is not going to be feasible for the child to follow because he's going to be unsupervised, right? They need treatment plan. So, and advising that the patient not go to the camp is not good as well. So we give medication, which is desmopressin. Desmopressin tablet is not used, nasal spray is used, okay? Tablet is nasal spray, oh, I did opposite. Desmopressin, nasal spray is not used in Australia anymore. Tablet is now used, okay? So we will give medication to the patient so that they will have no accidents during the camping period. Is that clear, guys? You can study enuresis from RCH. Let me just quickly open this guideline for you. All right. Let me share my screen with you quickly. All right. This is a whole topic of enuresis in RCH, which is tablet, Dr. Susmita. Nasal spray is not recommended anymore. All right. So enuresis is when patient is having bedwetting. All right. So red flags is patient is, you need to rule out if there is any secondary cause to bedwetting. You have to rule out whether they're not having any infection, any structural problem, don't have any diabetes, is not being bullied at school, or any family history of renal problems. After that, we need to make sure there's no secondary cause related physical examination. And then management. We have to do an investigation of doing a dipstick urine analysis to make sure there is no infection. If there is no infection and you are not suspecting on your history and physical examination, there is no secondary cause to it, you can give general advice for acute conditions, and then you can give that treat the constipation, make a routine, make sure that you are not having fluid before bedtime, make sure you're not having caffeinated beverages or soda at bedtime. Now, pad and bell alarms is the initial therapy which is used for enuresis in Australia. It's a basically pad and bell that tells the kid to get up and go and pee in the bathroom. But for pharmacological therapy, the pad and bell alarm is not working. You can use medication, and also in acute conditions like going somewhere, going overseas, going traveling, you can use desmopressin, which is a mini tablet. It's a sublingual tablet. Intranasal route is not recommended anymore because there are studies that have proven it causes high risk of hyponatremia in kids, which is life-threatening. Okay? Clear, guys? Anyone have any questions from here? All right, next one. 55-year-old man had severe central chest pain radiating into his left arm for the past 2 hours. No previous significant history, blood pressure is high, chest on physical examination is clear, pulse is regular. In addition to aspirin, what is the next most appropriate drug you would give this patient? Give amiodarone, which is a potassium channel blocker, pyridinol, which is a beta blocker. Give pain relief to the patient in the form of morphine, fentanyl. Give diuretic furosemide, or give ACE inhibitor, Ramipro. So this patient is having very typical features of cardiac-related chest pain. And for the last 2 hours, we are going to start the treatment of acute coronary syndrome. So they have already given aspirin, which is a antiplatelet agent, initial therapy. What is the next thing that you want to give to the patient who is having a heart attack? So we will give pain relief to the patient. Make sure patient is pain-free, fentanyl. All right? Yes, once you have given aspirin and clopidogrel, make sure patient is pain-free. Given GTN to the patient, we can start the patient on other, yes, should be nitrates. Should be nitrates as well. If nitrates is given, I would prefer to give nitrate to the patient rather than fentanyl. But most of the time when you will work in the hospital, you will see both things are given simultaneously. So we make sure that we have given dual antiplatelet agent to the patient, make sure that their vitals are stable, make sure they are pain-free. All right? Everyone agrees with this? If he is not hemodynamically stable, no. If the blood pressure is low, we don't give nitrate, we give fentanyl. This blood pressure is not high. I would not lower the blood pressure because this blood is pumping the blood to the brain and the heart. Blood pressure lowering 180 should be lowered to 160, 150. It's not less than that. Okay? Yes, 100%. ECG is the first thing that you need to do to make sure that you're not having STEMI, non-STEMI. Okay? So you can study from heart foundation. It's the basic things we have talked about that we go through. All right? All right, last question. Which of the following is an absolute contraindication to the use of medroxyprogesterone acetate as a contraception? Diabetes, breast cancer diagnosed in the past 5 years, past history of ovarian cyst, previous ectopic, or smoking. I cannot emphasize enough how important contraception is for your exam. They ask a lot of questions, sometimes 5 to 6, so make sure that you're quite well versed with this topic. So these are some are relative contraindication, but the absolute contraindication is breast cancer in the past 5 years. Everyone agrees that the answer is B? Let me show you guys the absolute contraindication to contraceptives. So has anyone heard of the MEC criteria? UK MEC criteria? So those are basically the contraception contraindications. So smoker more than 15, more than 35 for combined. Past history of VTE, ischemic heart disease, cerebral stroke, valvular heart disease, migraine, current breast cancer, diabetes with retinopathy, severe liver cirrhosis, liver tumor. And for the progesterone, it's the breast cancer in the last 5 years. Okay, so if you want to study, so if you want to study, oh, I keep messing it up. Sorry about that. If you want to study good contraindications, then you need to know that UK BEC criteria is the guideline to go through. How about female under 20? Sorry, what about female under 20? That was not a slide. That was just a Google search, Dr. Virali. You can search it. Female under 20, can we give DIPO? Yes, there's no age limit to under 20. But it's advised that over 40, you should not use DIPO. It increases the risk of breast cancer. It can be used in females under the age of 20 safely. There are two types of hormone responding breast cancer, estrogen and progesterone, ER1 and ER2 as well. Not necessarily, Dr. Sundar. You don't have to take the subscription. All right, guys, I hope you enjoyed the session. We'll have another MCQ trial class on the 17th of this month. So I will be using the same pattern about how we have done our session today. And it will be like that in your course as well. It's quite interactive. At the end of the session, we have the question and answers about different, whatever questions you have for your, regarding your studies, regarding any particular question, or regarding the course itself. 58-year-old man presents to emergency department with central chest pain, diaphoretic, ST elevation, low blood pressure. CT, can you please tell the correct answer? So patient is having STEMI and the blood, he is hemodynamically unstable. So we can't do primary percutaneous coronary intervention right now. We'll do IV morphine because option D is incorrect. We can't just give oral aspirin and observe. We need to make sure we give IV morphine and then make sure hemodynamically he's stable, then proceed to primary percutaneous coronary intervention. Dr. Arshan will upload the recording of the class on the first AMC group. Dr. Arshan will go through everything regarding the software on your when you join the course, so you will be able to tell where to go through correctly. You can't do a percutaneous coronary intervention or the blood pressure is low. All right. Thank you, everyone. I hope you had a good session, and I hope to see you in the next session on the 17th of this month. Yes, I would go with IV morphine. And then if there is an option, Dr. Pooja, of making sure that the patient, there's an option of resuscitation, do select the resuscitation option. Thank you so much, everyone. Have a lovely evening.
Have a lovely night.
No, IV morphine doesn't reduce the blood pressure that much. Fluids should be your best answer in this. Thank you.